Auzubillahiminashaitanirrajim. Bismillahirrahmanirrahim. Welcome back, guys. Today I'm going to discuss a topic which is very important in terms of obstetric emergencies, that is the massive transfusion protocol. So this terminology, massive transfusion, has came into existence since the war times, because in World War II and in the Vietnam War there were a lot of major injuries. So this is mostly, influenced by trauma. So it's more important in trauma surgery and for the surgery residents. But in obstetrics, scenarios of MOH, which is a massive or major obstetric hemorrhage, it comes into play. Now, ACOG says that the ratio of the products of the RBC to the FFP to the platelets should be 1:1:1. But then there is this thing that it should be 4:2:1, or it should be 2:1:1. And which one is better? Because the thing is that ACOG is saying 1:1:1, but when you open up the articles of the American hospitals, someone is using 3:2:1. They're using their own ratios according to their own hospitals. So why is this whole going on? What is better? The answer is, up till now, in most of the researches, clinically, no one is superior to the other. What is important? This doesn't matter. Don't fight over ratios. The ratios don't matter. What matters is how quickly you are triggering the protocol in your hospital. Are you waiting for the labs? Waiting for the labs, that is the fibrinogen less than 2, so I should order cryoprecipitate. Are the platelets less than 75, or is the HB dropping? No. Do not await the labs. You have to do your clinical assessment. So this is the most important takeaway message of this video, is that for massive transfusion protocols, ACOG is recommending these ratios. But these other ratios are also being used in individual hospitals. So your own hospital will have a ratio protocol. That doesn't matter. What is important is how quickly are you triggering this protocol. Because consumptive coagulopathy is going to occur, other issues are going to occur because of excessive blood only. If only packed cells are going on, then there's going to be hyperkalemia, hypocalcemia, and hypothermia, and all those things, and the clotting factors are going to be consumed. So you have to, based on what are you going to use now, you can use the shock index, which is the heart rate divided by the systolic blood pressure. If it's 0.9, the patient is very critical. Okay, normal values are very less than this value. Or you can use the blood loss. Now, blood loss can be either estimated blood loss or quantitative blood loss, quantified via the weights of the sponges. But if you don't have time, you can use your eyes and you can say, okay, this blood loss seems to be more than 1 liter and there's ongoing bleeding and we need the massive transfusion. Activate, pump, activate. But if you can quantify it using the dry weight technique and the sponges and the weighing machine, that's much better. But be quick in deciding that you need it, okay? For example, in placental abruption, the visual vaginal loss will be less, but the uterus will be expanding. There would be, the woody uterus. So you have to decide without waiting for the labs. Okay, so the success of this does not depend on this. It does not depend on, it depends on this. How quickly are you deciding based on your clinical assessment, okay? Then later on, once the reports come, आपने शुरू कर दिया रिपोर्ट्स में, आप देखें फिब्रिनोजन अगर ठीक है तो ज़्यादा तो क्रायोप्रेसिपिटेट मत दें उस वक्त आप, ठीक है। फिब्रिनोजन अगर कम है तो आप कहें भाई कंटिन्यू करो, एक और राउंड लगाओ एमटीपी का, ये सब चीज़ें हैं, ठीक है। एच बी इतना अच्छा प्रिडिक्टर नहीं है शुरू में, सही है। एच बी से ज़्यादा बेहतर आपका फिब्रिनोजन प्रिडिक्ट करेगा कि कितना बुरा पीपीएच में जाएगी पेशेंट मजीद। ये सारी बातें हैं जो कि हमें ACOG और बाकी आर्टिकल्स बताते हैं। सो अब हाँ, मैंने तो डिफ़ाइन नहीं किया मैसिव ट्रांसफ्यूजन प्रोटोकॉल को, किसी ने पूछा भी नहीं। खैर मैं खुद ही बता देती हूँ। सो बेसिकली व्हेन दी एंटिसिपेटेड या फिर आरसीसीज जो हैं वो 1 घंटे में 4 से ज़्यादा ट्रांसफ्यूज़ हो रहे हैं, या मोर देन 10 इन 24 आवर्स। अब ये जो डेफिनेशन है मोर देन 10 इन 24 आवर्स, ये बहुत ख़राब डेफिनेशन है, बिकॉज इतना पूरा दिन कौन काउंट करेगा और क्या पेशेंट सर्वाइव, अगर 8th ब्लड पे पेशेंट कोलैप्स कर जाती है या एक्सपायर हो जाती है तो फिर क्या ये आप इसे काउंट करेंगे मैसिव में या नहीं? नहीं, आपको नहीं समझ आएगी ना। इससे ज़्यादा बेहतर ये 1 आवर वाली डेफिनेशन है, या फिर और डेफिनेशंस भी हैं कि मोर देन 50% ब्लड वॉल्यूम लूज हो गया पेशेंट का, बॉडी वॉल्यूम, तो या फिर सिवियरली हीमोडायनामिकली अनस्टेबल हो गया, तो ये सब सारी चीज़ें होती हैं। थैंक यू।